You're welcome.
dedicated.
The other ones were just.
Oh, yeah, that's right.
What happened?
And Jamaica.
Yeah.
Some of our committee members are studying themselves. Jamaica and Antigua.
Yeah.
Okay, so you let us know who they are next time.
Well, you didn't set me the names, so I
Right,
forget.
we'll make sure we know who they are.
The other lawyer.
Oh, and English scraps in case somebody else is okay.
At the next meeting, we'll make sure they have to do lots of work.
Good plan. Sign them up for committees. Excellent.
Go off and sub yourself, that's not going to work. We also want to make sure there's nobody here in the room that is thinking that this is the abortion rule hearing that happened earlier. No.
Yeah.
It was in this room, just kidding, sorry.
That was the press conference prior to this.
That
Oh,
was,
is that why I saw CBS? I thought they were here for us.
That's-
CBS News.
yeah. They were, but we started late, so they left.
They settled for the other issue.
Don't call that. Anyway, I think we should go around and just make sure that on introduction, so we don't do that. Dave Richard with DHHS.
Kathy Nichols, DFA.
Why don't we do this? Let's confuse everybody, go around the wall first.
But threw me off.
I did.
Oh, sorry. Monica Hamlin, DNA.
Rose Burnett, ACBH.
Sarah Potter, and I'm confused. Maya Williams, DNA.
Oh gosh, where? I'm with DNA, DDSAS. All those, I'm in an alphabet soup all day.
I'm Rosemary Lala from DMH DDSAS.
Richard Keefer from Partners Behavior Management.
I'm Kenneth Fossell from DMA.
Renee Rader from DMA.
Lisa Jackson, DMA.
Karen Lucan, Easter Seals, UCP.
Jennifer Mahan, Autism Society, North Carolina.
Katie Short, here with her mom, Mary, who's not turning the camera on herself.
It's only fair.
Hey everyone, I'm Chris Egan with the North Carolina Council on Developmental Disabilities.
Carrie Earp with the Autism Society of North Carolina.
Curtis Bass, North Carolina Providers Association.
Tom Wilson with OE Enterprises at NCARF.
Mary Hooper, NC Council of Community Programs.
Beverly Moore.
Ashley Young.
John Nash, York, North Carolina. Matt Potter, advocate at large and representative of the Stakeholder Engagement Group, among many others.
Okay, review minutes of previous meeting, which I'm assuming.
You have them.
That helps for recognizing voices.
We did a lot without Kathy last time, it was very good. She just said. Everybody good? No objections? Cool. Just on the agenda today, we have a lot of stuff on here, and I'm going to have to leave in about a half hour or so. So we moved around and put the supports waiver on up front, and then we have a UMQR policy draft discussion, and then the drilling rate setting process in the afternoon. And I say that not really jokingly, later today, after the break. But Roger and Jackie are going to be terrific at helping people understand how this process works. Roger has been around for maybe 100 years at DMA, and Jackie, but they will, I think you'll learn a lot from them. So I'm glad you came to this meeting. It's a very important one in terms of how this process works going forward. Let me just introduce the conversation about the support waiver, and really it is that, a conversation. We just want to talk about it and get some sense from you guys of what you're thinking. This past year, in the governor's budget and ultimately in the legislative, final legislative budget, there was a special provision that requires the department to submit a report, I believe it's at the end of March, to the General Assembly, on would it be a good idea to have inside of the LME MCO, I want to be clear about this, inside the LME MCO, an additional home and community-based waiver, a C waiver, that would be limited, and the legislation says $20,000. At the top level would be $20,000. That's probably something that in a report you could talk about differently, but that would be what the legislation says. In order to assist people who are currently waiting for services to get off the waiting list. Now, I want to take a little bit of liberty just to talk about why that was in the governor's budget, the rationale behind it, and what the goal would be as we try to achieve this. One is that we know the process we're going through right now, create an individual budget, will ultimately allow us to have significant predictability about what the cost of the waiver is. But in all honesty, you start off in January of 2016. It will take time before the legislature is absolutely comfortable with that, and probably time for us to determine how to add a lot of additional slots at a level that we're able to move people off a waiting list. So there is some concern about that timing in that part of it. This idea was proposed mainly as a knowledge that we could actually do this with relatively little cost to state funds. In fact, we may be able to actually use some existing state funds for people that currently are being served as the match money for the waiver in order to bring these slots on. The legislation actually describes somewhere around 1,000 slots a year for 3 years that would open up the door for quite a few more people to come in. So that was the genesis of this conversation. Now, many of you remember that we had something similar to this in the past. And that was prior to going to the managed care waiver, we had a support waiver that was capped at $17,500. It served about 1,000 people in North Carolina. When the managed care, when LME MCOs went live in the managed care, those slots got rolled into the comprehensive waiver inside of there. So it no longer exists. The key things to think about as we start the conversation is, one, the idea is that it is intended to be a lower cost waiver. Many states do these. You can't necessarily say it's only for people on waiting lists, but that's sort of the theory that most people have done. Clearly is for people that don't need as high of intensity of support, but it allows us to use federal money rather than state money to serve a lot of people that we currently serve under pure state money. So that's the positive side of it. Some of the things that we've heard from people on the other side is that, one, it becomes difficult to manage. In the LME MCO, you're managing two separate C waivers. Two, how do you move people between both when there's needs gain or there, and is that a logical way to do business? And, well, I think those are the two main issues that we hear from people. So we know that we recognize there are issues on both sides. What we want to do is to bring it to you before we start trying to figure out how to draft this report and what we think are the recommendations that ought to come from the state. Obviously, it was in the governor's budget, so there was some interest on the administration in looking at and exploring this, so we want to be clear about that. So, that being said, kind of opening up the conversation.
What you said a few moments ago, I have a bit of confusion, is the service you're talking about in order to do something to move them into a service, or is this a service to keep them going while we're waiting for the other service to start?
No, it would be, the way you would see this is that it clearly would be for people who currently are not on the C waiver.
Right.
It may be that people are receiving state-funded services, so there wouldn't be that necessarily they would be off of services, or it may actually be that they were receiving some B3 services that they could move on. So it wouldn't be that while we're waiting for the comprehensive waiver for these individuals to be there, but it would be for a lot of folks that I think we all know there are people out there that could use a little bit of service now, and there's nothing available for them because of the lack of resources that are out.
So what does it do?
That's part of the conversation. In the old waiver, I think we remember what the services were.
In the old waiver, the services were the same as the comprehensive waiver, with the exception of there was not a residential supports definition. Additionally, there was self-direction under the supports waiver, but not under the comprehensive.
So, and again, no preconceived notion of what we would put in it. You know, it's more of this conversation to see what people think about it, because you can write it just about any way you would choose to write it and what services would be available.
Once again, where does the match come from?
Match would be, right now, there is no match identified, but we spend a lot of state money on pure state services for people, that you would make an assumption, and so let's just use this math. If you did 1,000 people on this waiver and 500 of them currently receive state services at $20,000, and they could be on this waiver, then you actually wind up creating additional funding that might be available for people to be used, because you're using that $7,000 match for that $20,000 rather than the $20,000 of pure state money. So that's where the match would come from. And I'm get you to introduce yourself. You're a guest. I invited you to come, so why don't you tell everybody who you are?
Well, I'm Melody Campbell. I'm the director of Carolina Psychocare Agency, and I'm also on the provider council for East Point.
Oh, nice to see you.
Yeah. And I like to say that support waiver, when it first rolled over from some years ago, that really helped a lot of consumers. They got mainly more, the same services that the other care people did, and they got 3 hours, 3.5 hours, 4 or 5 days a week, and that really gave a lot of families a lot of support. You know, even though they couldn't go on a comprehensive waiver, it still gave them a lot of support because they didn't have any services at all then.
Eligibility requirements identical to a comprehensive.
We would structure, I mean, a lot of it depends on what you apply for, but yeah, I mean, it would probably be the same level of care requirements.
The level of care would be the same. It would have to be ICF level of care, but we could design parameters around whether or not it's strictly for adults, or if there are other things that we can target, but it will be the same basic level of care.
Strictly somebody that would be eligible or is eligible for the C waiver, but just is not.
For the level of care requirement, right? Although we can't put
So we're not
parameters
expanding,
on it.
we're not expanding the eligible population.
No.
The only concerns that I've heard from other client advocates about this, and it's been a hotly contested issue, I feel like, not in principle, but in execution, or theoretical execution. The biggest concern that people have, I think, is that they're afraid that people will get this smaller sort of support waiver and then be locked into that and struggle to get a more comprehensive waiver. Like the example that I've heard used is, you know, a family that's desperate to just get anything, you know, applies for this $20,000 waiver, doesn't give them what they need, but at least gives them something. And then fear is that that would sort of lock them into this smaller waiver and they'd have trouble getting the more comprehensive
Well,
one.
you wouldn't lose your place on the waiting list.
That's actually a very important.
I think that's a really important component. If you do this, you would make sure that if you were waiting for a comprehensive waiver, you would have that opportunity. What I can't remember, Deb, is that when we did the 1,000 previously, it took a little while for people to get to those 1,000, but they were all allocated, as I recall. And I don't know that we had a lot of problems with that from people, but it was only implemented for a couple of years. That wasn't a mistake?
It was only in place for a few years. And you're right, you would maintain your place on the waiting list because you can't deny someone access to the waiting list if they meet criteria. If they're going to meet criteria for this waiver, then they would ultimately also meet the same criteria for the higher waiver.
But can can we structure it, one of the things that we may be able to do is instead of structuring it according to from first come, first serve, maybe prioritize
For
by need.
prioritization.
That was going to ask a question.
You asked me a question and I completely.
No, you answered it.
I did.
Oh, no, the question was, so you called, were there many, I do remember, were there many, did we have many instances, and Rose, you may remember too, instances where people had gone on to the support waiver and then almost immediately were desperate to get something else and we were having a,
There were a few.
but it wasn't overwhelming, I guess.
No.
But it wasn't because they lost their slot, I mean.
No, right.
So it's very clearly set up as a transitional type of support.
Well, and I think this, well, I would say,
No, the old one was not.
yeah.
And I think it's a little scary to do that. I mean,
Yeah.
you didn't ask me. I'm
That's what it
sorry.
sounds like.
You have every right to say that to them. I think that, I don't think the intention, I'll say this, it's part of sort of the conversation about that a lot. The intention wasn't that necessarily was a bridge to a new waiver. The intention was that there were a lot of people that just need a little bit of service. And that a little bit of service went a long way to making a difference in their lives. And for many, it may have delayed the need for more comprehensive services. But there was, I think there were people that says, well, hell, I'm going to do this because it's the only thing I can get, although I need something more. I think that's.
Then with that in mind, is there the potential that there are people that are receiving very comprehensive services that may not need that level of support that would transition back to
That'd be a hard
smaller?
sell.
I agree, that's why I'm asking the
I don't think we would
question.
do that because we're already going to be doing some of that as we think about the resource allocation. That'll be part of that process for the comprehensive waiver anyway.
I mean, God bless your heart. You let me know how that works
I'm
out.
just asking the questions that are going to come up.
That was something that was done with the supports waiver. And it is difficult, especially when there are one-time costs that you're going to either make the cut because you had a home modification or you're going to not make the cut because you didn't need it until this year. So I think that pulling people out of innovations I don't think that would behoove us.
So I know this is a stupid question, but there's probably somebody else in this room besides me that has this. Why could you not ask for that same amount of money just to go into new waivers, regular waiver slots? What's the advantage?
Because the number would be, the number of slots would be significantly lower. Our average cost in the current waiver is 60.
65?
Yeah, so you're talking for the same amount of state money, which, we calculated at 7 million, actually be a little bit less because nobody would spend the entire amount of that money in their waiver slots. You would essentially get a third less people on the waiver. And one of the other issues that I think that, and I may be wrong because it's really hard to do any of these calculations, but I would speculate it would be very difficult, much more difficult by doing it that way to assure that you did not reduce services to somebody by having to take that 7 million out of the current allocation because of the high dollar amount that you would be paying. A lot easier to think about because state services don't spend a lot of money. So you most likely will get that group of people in this support waiver. Yes, ma'am.
Around 2007, 2008, my son became, or I guess there was a change in slots, so they were no longer a fixed budget, but you could allocate less among.
Oh yeah, we had an aggregate funding thing for a little while.
And that's how my son got in. And we had a low amount. His need was, it was not based on his need. It was based on whatever. So that went away. We're not doing that anymore.
Not doing that anymore, but it is something that we have to look at in this amendment to the waiver when we're doing the research about how we can do that because under the legislation that created the LME MCO managed care organizations, we are required to do that. It's a technical issue that I think we have to review and see if CMS will allow us to do it under the waiver. And that theory, just for everybody else, the theory was that right now, if an LME MCO, and please correct me if I'm wrong from that side, is that if you get, let's just use this number as 1,000 slots, and for those 1,000 slots you have $5 million, and you actually spend, we're going to show that you'll spend $4,800,000 or $900,000, and you ought to be able to open up 2 more slots, right? And that's not allowable under the current waiver.
It's not allowed.
Well, but part of, because if you're doing this out of savings, that's,
In that short term, I don't know when you'll have that.
we
each
could do
year.
next year.
That's exactly right, that's right.
So it's sustainable.
I guess that may have been what they were, I don't know.
But it seemed to work.
It did work, and it made sense, because if you had people not using their full slot every year, and it was ongoing, I guess, it did make sense to spread it out.
Well, and the other thing that I think it did is I believe this is correct, is that for many families, the idea that if I spent less, it goes right back to the general fund, wasn't a very appealing idea.
It's not an incentive.
But if I spent less, and maybe my neighbor or somebody I know might have the opportunity to get services, even though, I mean, I think that was a culture change that began to happen, and we saw it happen.
Dave, can I ask a question?
Sure.
When you talk about using state funds to support the match, this is probably a stupid question, but does that mean if the supports waiver went through and that occurred, that the MCOs would have less state funds, right? Okay. So for anybody else, so let's just say it all happens, you get 1,000 slots per MCO or however that all plays out. So 1,000 people get services, but the MCO won't have any state funds to support anybody else. I'm just trying to understand that.
I mean, we'd never take all of state money.
Okay,
A small amount of state money to do that, but the danger, I think that's a really important component. It's one of the ones that we have to really be clear about. The danger is that so many ECBH and coastal together, there is, of the slot allocation, there's 100 slots, say, of those 1,000. And for that, we take $1 million, probably the wrong number, but so that winds up happening. If on a statewide basis, I'm confident that the people that you had, 1,000 people, of that many, you would probably have enough people that would go under waiver that were receiving state funds, that wouldn't be an allocation problem. You wouldn't lose any money, in fact, would gain probably, because you would have this extra funding that you're receiving in the waiver slots. But on the LME-MCO by LME-MCO level, that's where I think we might run into a little bit of difficulty because the numbers are smaller, and so they'll spread it out as overall much true. Again, I would say that one of the things you would tell us is don't go forward if you're going to wind up taking services away from somebody, and make sure you got that figured out.
But is the emergent, when we go down that,
Yeah, I think it's much less of a risk the larger you are, but that is one of those risks. I would think trying to do this LME-MCO by LME-MCO when you had 12 or 11, however many you had, was more of a risk. Down to 7 becomes less of a risk.
it seems for you guys to be a really administrative nightmare to try to oversee.
But it's not about us.
For those of us supporting people with 10 different MCOs.
I appreciate you being in the Christmas spirit and thinking of others.
Because that's what Willie would do on the same side of it.
It would have been a nightmare.
It would have been a nightmare.
No, I know, clearly.
So I would echo the concerns around folks who, because that happens now, for folks who are on the wait list receiving state-funded services and or B3 services, it's a much lower level of service than what they really need. You know, so that's that same concern, again, if we're gonna go in chronological order of the waiver, and somebody comes up and moves this.
Well, but, and that's kind of one of the things we can change.
Right, so that would be one that I would note, and then.
So you'd be taking people off the waiting list with less need first?
No, it wouldn't be taking people off the waiting
But
list
with
at
this
all,
extra
but
waiver.
to figure out who gets these slots, you might be able to ascertain higher level of need, as opposed to first come, first served.
So it may be that one of the things that we think we've learned is that the intensity does not necessarily equate to the same thing as the emergency.
Right.
So you may have somebody that has very low need for a lot of service, but that if you don't get them something soon, then
You've got stability in there.
that's right. The need's going to be really significant later. So you've got, I mean, a lot of things to consider in that conversation. I don't think there's any question about it. And just one more part is that the whole idea of even proposing this is a recognition that regardless how generous the General Assembly may choose or not choose to be during the coming years, if you've got 10,000 people on a waiting list and your average cost of slot is $60,000, then you don't even want to try to do that math. And it is not something that I think anybody could reasonably expect there's going to be significant movement at a high level on that, considering the ultimate cost. I think there's great opportunity for incremental movement on that, but there's not going to be a big splash. So the idea is that can you do something that you guaranteed a lower level of cost that actually gets a bunch of people off the waiting list, not off the waiting list, but gets them something.
So I think what would be probably useful is just, in general, if you all had people that were on the supports waiver, what was it called?
It's called the Supports
Oh, it was,
Waiver.
I don't know, but like, if you have feedback about what worked and what didn't work, then, that you could send to, I guess, Renee, because we don't have anything that we've written for you for this or anything, I think it's a conversation, but, because
Also,
the report's due, right, it's just a report that's due in March, not even structuring the waiver, which will be another probably discussion of stakeholder group and all the rest of it, but.
From a practical standpoint, anytime that we can pull more resources into the system without costing the overall
Leverage
system
them, right, yeah.
an additional dollars, that's a good thing, and it's just the devil's in the details. How do you work it out? So, I mean, to pass by the opportunity without saying, okay, let's do this and worry about the details later, obviously would not be a wise thing, but to pass the opportunity period says that we have a chance to pull down a significant amount of funding that will affect the lives of somebody, somewhere.
So I don't know what your goal exactly was to put this on the agenda, but this would not be the primary stakeholder group.
No.
Or maybe it will be after we finish with the
Right.
first thing. No, you got
Well, by the time you have to ask the first one, you might be there. It's more of a get a sense of what people are thinking, and then what I would suggest that, because I do think we would want to come back to this group with maybe some ideas just to get a little bit more feedback, and I'm thinking that we would do that near the end of January. And test some things out.
But it would be a new waiver, and as a new waiver, it requires.
Oh, yeah. Just more advice around our, I think, more transparency and advice around our report to the General Assembly.
If it were in my front of me to have to deal with directly, and I had to choose between having the stress of figuring out how to spend the money versus the stress of not having the money and wondering what I'm going to do to fix some of the problems that I have in front of me, I just as soon choose the problem of have the money and worry about how to fix it than not having it, shrugging my shoulders and can't do anything about it.
So, you know,
I do want to just note that you do want to have enough funds, and we can sort of debate whether $20,000 is the right to offer the intensity of services that is really going to make a difference. Otherwise, we're spending money that may not be used effectively. And so just so that we're keeping that in mind as we're talking about what a supports waiver, who it would serve and how it would best serve people.
Yeah, that sounds like it probably relates more back to the entrance, to your entrance criteria, yeah.
Or to making sure that you don't create a series of waivers that leaves a significant gap for a group of people out there. That, you know, if you're considering a supports waiver and you recognize that there's a group of people who will not be best served by that, that you think about how, you know, is there something in between what we have, which is the $60,000 a year, and a supports waiver, which is 20, and who would be
and
served?
there will be, I want to be clear about this, there will be something in between. In between will be this comprehensive waiver that's based upon individual budgets, which will allow for that management of budgets that essentially tiers the waiver in many places. This is the idea was this would be essentially not below what anybody would get in a comprehensive waiver, but probably at the very low end, and very few people in a comprehensive waiver would be getting less than $20,000. So in some ways, it's a supplement to what the comprehensive waiver would be, with an absolute knowledge of how much money you would spend. You know, the absolute cap at 20,000 gives, you can't get any better assurance of what the top amount of money is than that.
I think we would need to be careful too, from some of the concerns I've heard from other groups around folks that are receiving a lot of, I say, dollar services or in some of those residential programs that we have so much concern about. And if we include residential sports, obviously, because that's a.
And you would have to look at the amount of money versus what services could be offered. It would not make any sense to include a residential service when that can't be supported at 20,000. So are you gearing it more toward people having a meaningful day? Is it going to include respite? Is it including some assistive technology, which will enable people to stay in their homes for longer? And so it will probably be a smaller service array and more targeted. Those are the consultation.
I'm not sure, because one of the things that, and I don't know, I know you think about this on the side, but I'm not so sure that considering what people receive inside of people who are in a residential setting that's dealt with through Medicaid and the state rate for, say, low intensity, I'm not so sure you wouldn't fall into that number with something at 20,000 below.
Well, I'm just saying it's
No,
not
no,
that it would include the group, folks in group homes maybe, but it wouldn't include residential.
I see what you're saying, got it.
Say again, I couldn't hear.
It's not that you would exclude people who are living in group homes or residential settings, but if they didn't need the residential supports, then it would accommodate for the day and the inclusion in the community versus the innovations waiver, which covers the residential support component. So we won't be leaving people out, we just wouldn't provide that service because you wouldn't be able to for less than probably $40,000 a year.
Now, is this renewable? I mean, we're going from year to year to year?
Yeah.
And if 2 years down the road I'm on this thing and I get picked to be on the good waiver, then my slot is open.
That would not be the way we characterize it. You want to eliminate any of that conversation at this point.
But then I leave this and that slot, 20,000, then goes to someone else.
Yeah.
Yes. Yeah.
Yeah, I mean, I think that, yeah.
So we're permanently adding these, it's permanently up to me, adding these slots.
It's almost like a revolving support fund.
That's what I'm thinking.
I mean, I think that there's some way to do that. In others, again, I'd say other states have done this successfully. We did it successfully, which is one of those things that is, I think, now, albeit in a different system, entirely state system, except for Cardinal. That's very helpful. What I think we'll come back with is so the comeback will be is that if we chose to report this way, would this make sense to you? And we'll try to do that at the end of January.
So,
Dave, can I just say one more little thing? Just as a
Sure.
thought? At least the way it was in the previous supports waiver, people have to, the CMS requires with any C waiver that you indicate that the person can be supported within the bounds of that waiver. So you have to be careful and make sure that if someone receives a $20,000 supports waiver slot, people's lives change, right? And some people will tick along and they'll do fine in that waiver. But if there's a situation where their needs increase and they can't be maintained safely supported on that waiver, you have to have a mechanism to deal with that so you don't go from 20,000 to nothing.
And what we can do with that is we could look at moving some of our reserve capacity slots.
Okay.
And
A waiver to waiver?
adding a couple of reserve capacity slots to the waiver that says, we are holding these slots in reserve so that an individual who is currently on the supports waiver and has a change in circumstance and cannot be safely supported under supports waiver can move into the comprehensive.
and I think it'd be really good, Rose, to have, what we learned last time, Just because.
I'll have to have some sort of brain surgery for that, but
Yeah,
we will absolutely, we'll do some data mining. How about that?
Yeah.
I think many of the MCOs, because many of the MCOs have staff
Yeah, that
in
were the
current
only
positions that were in positions at that point in time as well.
Okay. We'll make sure we communicate that.
How would that mention, random question, how would that impact like your B3DI services? So somebody who's currently, I mean, those are time limited and whatnot, I understand that, and based on money. But if you're using one of the, see what I mean, like, does that impact the ability to have those services or something like this?
I would think so. I mean, if you're talking about B3DI, so you're looking at somebody who's currently in an institutional setting, right? Developmental center. In most cases, not all, those individuals have significant needs. not always, but most of the time. So
I mean, I think it's
just generally, I think it would be hard to support somebody in that category, and I'm sensitive to people, but on a supports waiver, it would be hard. Not impossible, but it
but
might
you
be
could
hard.
continue to have to be together.
Happy holidays, Dave, have a good Christmas.
Yeah, I don't know that I can really answer that, because I think it's a separate pot.
Good behavior.
I mean, with the big three, you have to identify that. I mean, currently, the way that's identified is just as innovation services.
But you know, it's like the baby in the bathwater, right? I mean, there was some good in it, so let's talk about it.
There's a lot of good.
So we're gonna segue to Kenneth, my friend Kenneth, over there, who is on here to discuss the UMUR policy draft, which I just passed out. You didn't get them when I walked in, when you walked in, because they were still busy resetting up their everything. We got a little bit divided in there, but.
So, I hope everyone's doing well. We didn't.
Did you do that?
Merry Christmas, Deb.
Hi, Deb.
Thanks for everything, happy holidays.
So we emailed this out about a half an hour ago, and we just wanted to get it to you guys to see how we're going, so that you can give us some feedback. So this is what we have so far. It's still a work in progress, and we're beginning to look at kind of how it fits up with our current clinical policy 8P, which is the policy for innovations, and documentation rules, all that kind of thing. We've heard a lot of you guys talking about some of the documentation that you do, you don't feel like is value added, but some of that's in the waiver. So how do we start looking at different types of documentation, like pie charts or narratives, to start seeing progress, not just as like entries on a chart, but actually, looking at life changes, things like that. So we came up with this policy. There's a few questions, or one question embedded. It's basically the same information that was on the PowerPoint that you guys had a presentation in November. And one of the questions just to think about is, we heard that you guys didn't feel like a post-review was a good name for going back and looking at services, so we gave you some options. We chose reflective evaluation, which is a word, but I'm not sure if that really means anything. So we did post-review, post-evaluation, reflective analysis, retrospective review. We just kind of threw it out there to see what you guys thought it could mean. It doesn't have a negative connotation, because again, it's looking back at services, seeing how they're delivered, and trying to shape the service more on the back end.
I actually think reflective evaluation is pretty okay. I mean, you're right in the sense that it's kind of not like any other term I've heard for anything really ever, but I think that's kind of a good thing in the sense that it's like, we're trying to get away from it feeling like, oh, this is some huge thing that's gonna, potentially have an impact on this, that, or the other, or, it puts pressure or concern on the family or whatever. Calling it a reflective evaluation, I think, pretty much encapsulates what its purpose is. So I actually think that's a pretty good term, but that's just my 2 cents.
Thank you. So again, this is kind of basically what was on the PowerPoint that you're shown. So we go through, we have some of the things that are going to stay the same, the 135,000, how due process rights are going to stay the same, requests are going to come through to the MCO, so all that's the same. Then just briefly to go over, and again, to give us feedback later, we kind of broke up the whole UM process into 3 categories: prior approval, plan review, and utilization review. And then within those plan review process, we broke it out again for health and safety. So that's what we talked about. We would look at health and safety, but not necessarily to deny a plan, but to look at it in the context of how do we shape the system, or if we see something that's not being addressed, how is that corrected? If there's a lack of capacity for something, how is that corrected? And of course, that would go back to care coordination, but there are other avenues that it may take. And then waiver compliance, all the services, even though you have your budget, your request has to meet the waiver. And then support needs. And the support needs is kind of what we talked about before, is if you have temporary needs and permanent needs. So if you are within your budget and you have a temporary need, like fall, something like that, you have something for 6 months, we need additional funding and we need additional support, there's a mechanism for that. And then there's a mechanism if you have permanent needs, if you're outside of your clinical description. So we kind of tried to get it all on here, and since it just came out 20 minutes ago, I just kind of wanted to give a little bit of an explanation and then to get your guys' feedback now and then going forward to see if we're on the right track. But, there's information to digest, so don't feel pressured to give feedback.
I might just reflect on, and I know it's a tough one, but I get in moving around the state and talking to different people and listening to members of the council, there still seems to be a strong theme of confusion or maybe not being fully aware of the steps for due process. Just a reminder to be really clear on transparent as possible.
Right. Okay. Okay, that's a good point.
I would also suggest somewhere in here, we talked about this towards the end of our session last time, how is support needs moving towards meeting outcomes for people? Are we doing something more than just supporting and ensuring that the safety of it? So put that, and maybe it's within the support need conversation, maybe there's an outcome section.
Okay. Right, so that's another thing we're talking about right now we're going through is how do we determine outcomes? We don't want to use something that just looks at constant progress upward because we know that that's not realistic for anyone. We all plateau at certain points. So, we're looking at outcomes, and that's part of why the draft.
Wouldn't that be part of the reflective evaluation?
It could be, right.
I'm not sure, I really like the term reflective evaluation to the extent that I can understand the process. I think it would make great sense from the perspective of the family and the consumer. I'm a little worried about that term relative to providers. Because I think, and Rose helped me out, but under the waiver, utilization management is a term that is a requirement. And I'm not sure how folks would feel about reflective evaluation. Sounds very soft to me, and softened, and that's great in terms of the individual family, in terms of the provider organization, and I have great respect for the provider organizations in this room. I think what we're still talking about is utilization management.
Right, so I guess just to give a little bit, all of this document is the utilization management. So what we had before was the term, I think we used a retrospective review or post-review. And so for a lot of people in this room, they felt like that was, someone might go back maliciously and look at things and find problems. Instead of, we're thinking about not necessarily looking at individual cases, but looking at the system as a whole.
It's a culture change.
Right.
We're trying to make a culture change in utilization management under this new waiver. So that your front end piece is not necessarily so much about, choices would be more heavily weighted as you're trying to figure out what goes into the plan as opposed to a lot of the front end.
Right. Yeah, no, I don't disagree with principles. I guess it takes me a little bit.
The names.
Well, and there will be providers that are providing services under the other part of the waiver, as well as private insurance, which it is retrospective review, because that is what it is.
But I think that where the confusion comes into that, though, is often with the retrospective review, is more with an eye to denying or approving a service and then billing for it retrospectively. If they might have retrospective coverage or there's a retrospective billing process, that does get tricky, the term retrospective in EUM. Everybody likes your social work term there.
Yeah.
So is this similar to the implementation review that the NCOs do?
Say it again?
Is this similar to the implementation review that the NCOs do?
Can you explain the implementation?
That's when they come back and look at your services for the past X number of months.
Post-payment.
No, this would be separate from a post-payment.
Yeah, that's
This is
provided
looking more
monitoring.
at system-wide.
I just wanted to add an additional thought. I understand the concern, as far as providers might, want something a little more firm. But I really want to emphasize that the word review at its core kind of implies that something needs to be changed. Like, I can't think of the last time I heard someone say, oh, I'm going to review this, and have it just be, oh, I'm doing it as a matter of course. Anytime you hear someone say, I'm going to review it, it's because they need to double check and make sure that nothing needs to be changed. And so the nature of the word review immediately puts me, and I'm sure plenty of other people, in the mind of, oh, something's going to get changed. They're reviewing this. That means something's wrong. So that was my concern with the term retrospective review.
Any kind of audit
Yeah.
process that I've ever gone through, the common knowledge is there's always going to be something wrong, and if they don't find something, there's something wrong with the auditor. And that puts us immediately at the point of, we're guilty until proven innocent when you go into that kind of a review process.
Yeah. That's my concern.
Right, so I guess, so give us your feedback. If you like this term, if you like another one, if you think something should be different, and we'll definitely take it into consideration. But those were kind of the things that we were thinking about, is how do we explain the process, how do we make sure everyone knows that it is looking back, it is retrospective, but not have necessarily a negative connotation.
Quality control.
Right,
Yeah.
and how can we have a culture change and a culture shift, but also, make changes meaningfully and evaluate things meaningfully.
Let me ask this question. What is the purpose of the review? Is it to review the individual? Is it to review the service? Is it to review, let that drive let what you're trying to have happen drive the terminology and the focus on this?
Right, so if you look at that paragraph, it kind of has, right, so it can be for the individual, the provider, the service, the clinical descriptions, and also the model. We want to ensure that the services support the delivery and achieving the outcomes desired. So it's not just, pointing out one individual, but it's looking at the individual, the meso, and, the macro levels. I did. Which one?
He's a nurse, he doesn't want to sully himself with the rest of us.
So it can be to gather information, determine benchmarks, identify outliers, monitor service arrays, review outcomes. So it's a big process. So that again is one of the issues.
Who does it?
That would be done by the UM department.
Of your MCO.
Right.
Yeah,
So
right.
this is,
The scary.
talk more.
So, if you have any other questions, we can talk about that now. If you want to give feedback, I believe our next meeting is in early January. Well, for our event type stuff. So, during the holidays, that week after, if you can get some information back to us, that would be great. Just to let us know if you think we're going in the right direction.
So this is, we do have policy,
Draft.
correct? And then under this, are there procedures?
Well, so, again, as we've been in these meetings, we've talked about how we want things to be more flexible.
Yes.
So, and we talked about if we write explicit things down, then they might be, it's harder to change the culture. So we're trying to have it be more open and then go into specifics as we need to.
But you may be, what you're possibly asking is, does it mean, will we ever see, and we don't, because that's done differently. At what level of service do you qualify for this? Is that what you mean? If a patent qualifies for services under utilization management?
Well,
That
or,
wouldn't be,
I just remember there was something about one of the plans that we were working on, that I get the certified letter saying part of it's not approved, and I had X number of days to do something if I didn't. And it was all very, surprising and legalistic, and I guess that was our MCO's process. But
That's due process, right, so somewhere in what
but
you.
they were just gonna look at something. In
so
fact, they were helping
it was
me.
your peer review process of trying to ask for additional. So service was denied, reduced, or, yeah.
Yeah, and it sort of came out of the blue because we thought everything was getting approved. But, so I knew there was a procedure somewhere they were following, but it wouldn't come up, this is just the overlying policy.
Well, so the due process isn't gonna change per se, like if in this process you found out that, if there was a denial or a reduction for some reason.
Or questioning whether a certain service was the right service.
Sure,
That was
that
what the
letter
issue
would
was.
still be generated and,
But that's under the due process.
The
you
process
still
is
have
back
the
into,
ability
this is
to.
what's coming, what we get coming into the system. We have a disagreement concerning the process kicks in.
Right, well, I mean, because okay, let's just be clear, I mean, the reflective review is evaluation, I'm sorry, I don't know what we're calling it these days, but that's not even a part really of the current utilization management process, that's a separate and apart piece.
Right, okay.
So, and it would not necessarily, and I don't believe that there's negative connotation, I think it's just looking at it, did what we do work?
Right.
Did it get it
That's
through?
the reflective thing.
Yeah, but there still will be a piece where you've done a plan with somebody, and you figured out what your services want to look like, and you figured out, based on your base budget and all that kind of stuff, where things are gonna, and you're gonna figure out what your plan year to look like, and you may still have services denied under that plan year.
So I guess due process is triggered if when it's going through this
If
policy,
somebody
if
reduces
UM
the
decides.
front end of it.
Yeah. Got it.
But there's still a back-end process in it too, just to, but I think that the goal, because utilization, so, let's see if I can say this, like what I'm thinking, but like, I think that it's just a culture change that they're trying to achieve with utilization management, because you still should have some more flexibility with within the sort of band that you're in under resource allocation, so that you can, so it's less about like, do you need medical necessity for X amount of hours, and making it quite so regimented, that's a good word, and so that you have a little bit more flexibility with like, okay, I'm probably gonna need all these things. How am I gonna make my day and my week and my life meaningful under this budget within this context, and make some choices for myself and what kind of works for me, so. That would be kind of maybe the difference in the philosophy between.
Are we evaluating processes or outcomes?
With the reflective, whatever, evaluation,
Already
all
whatever
of that
mission
is
given.
what I understand that their proposal is for, would be all of it.
So it's process and outcome.
Yeah, I know, that's the one that Cindy gave that presentation.
Yeah.
And that's where we were talking about inserting some of the kind of quality measures stuff.
Yeah.
For the individual though, yeah,
So that's what we're actively looking at now.
as opposed to the whole waiver, yeah.
Right. Yeah. And then again, so one thing that we're, makes this process difficult is a few weeks ago you guys had a presentation from service definitions, and as things become more integrated and services become more combined, that makes that 15 minutes of personal care versus 30 minutes of community networking less of an issue. But we don't have all of those details to put that in necessarily now, or it's a cold context.
Yeah.
Yes.
So I have a question concerning with utilization and any conversion that we have from a habilitative service to a non-habilitative service. We talked about this blended rate, and I'm worried sometimes that in our day support options that people have and their residential options that they have, that there'll be more just a movement towards custodial care rather than a quality habilitative care that meets the needs of people with high acuity that need ICFMR level care. I mean, ICFMR level care is fairly defined. It's a comprehensive service. It includes medical and habilitative services. There seems to be a trend currently happening, not projected to happen, where utilization is being reduced. And there's conversion to group and to less habilitative services and to more personal care type or custodial services. That's a great fear for people that are as old as me with gray hair, like I have, that have been fighting for folks for this many years. And I'm worried that there will not be, in the resource allocation, adequate dollars to support their needs. It will become more of a cost control exercise than meeting people's needs, and I have great concern about that.
So how would you suggest to put it into the model to kind of check that? Because, philosophically, that's not what it's supposed to be. And I see where you're coming from. How would you fix that?
I do think that there is a firewall between care coordination and utilization management. I would say that firewall has been somewhat, again, I'm talking on a statewide basis, somewhat nebulous, as more and more screws continue to be tightened and tightened. And so I think that DHS, to answer your question, DHHS has a role in their oversight of the waiver, that it meets federal requirements. And with that, we have to be sure that we are meeting the needs of people in that level of care and monitoring of our care coordination system to ensure that the adequacy of people's needs and that the service is accomplishing what the individual needs to have accomplished through the
So would
service.
it be a care coordination measure, or would it be the overall outcome measures for the? I mean,
Yes and yes.
I hear what you're saying.
Yes and
I'm trying to
yes.
Understand.
I
And
think-
Mary, you're dying. You let me finish.
Oh, I know.
So I think you both. I just think we have to put in place.
Care coordination measures per se. I mean, what do you think?
I'm sorry, say again.
What kind of measures are you thinking would be care coordination measures?
Have always seen care coordination as a service for about 20 years, and still see it as a service, not a administrative function.
Sure.
And with that service should have the same level and scrutiny of oversight as any other service.
Well, we do. We do look at that when we go out on our annual reviews, and we're looking at various measures every month. But I don't know. I guess what I'm saying is that it would be helpful to and you don't have to necessarily answer these now. We can reflect on it a little bit too.
Right.
But if you look at the way the waiver is structured, there's some measures that you have to put in there, and for the different sections, and it's things like medication errors and health and safety measures. It's actually very strongly weighted towards health and safety measures. what you're kind of talking about, or maybe looking at some more robust quality type measures that we really don't have in the C waiver right now, and partially because it's not what's required in our submission to CMS. But that's not to say we can't have additional measures. You know, you can measure, you know, but what should they be, and how do you really structure that? What's the numerator and the denominator, and how, you know, is it really measuring what you're going after? And that it probably is a much bigger conversation that we're going to get into in the next few minutes here. But creation of those measures is A, not easy, but B, the more specific input into what, you know, you're trying to look at and measure would be helpful. And because I think, you didn't say this, I think that the measures in the waiver right now, okay, that's fine, they're health and safety, but they do not drive to quality at all, and I think they're terrible measures, frankly. So.
I guess the key phrase that I'm looking to, I think that each service, even though in IDD we don't have established best practice services necessarily, as they do in mental illness that are as clearly defined. And that's why the outcomes, you know, I like your response. It's both an outcome measure and a care coordination, monitoring, and oversight. But the bottom line on behalf of people is that the efficacy of the service is achieved. Meaning, if we're going to order a service, as the doctor orders,
That's the point.
it must meet that needs of the individual. And if we, you know, reduce our quality and our outcome measures and that kind of thing, such that you will lose your quality providers, and you'll only have the lower quality providers that survive. And we must maintain a quality and funding of service, and funding is not just rates. It must be a number of hours of service to accomplish the efficacy of the service for which it was ordered or designed.
So what about this? What about in the new year if I bring you the measures as they currently exist, and we can't really get rid of them probably because we're going to have to still submit them to CMS, and maybe as a group, we, you know, and maybe, or going back to your own groups, we can think about what it is we really want to measure, and how we can kind of come up with that piece. I mean, we're doing it in other ways with your care coordination, for example. We're starting to look at how many people are recidivism and PRTFs, for instance. I know that's on the mental health and substance abuse side, but that's one of the things we want to see the care coordinator do. You know, make sure we have a adequate discharge and that they're community wrapped when they get out, so that they don't do that. An average length of stay after the hospital, so on and so forth. So, but we have not been as aggressive with C waiver measures, absolutely. So I can put that on the agenda, and maybe we can talk about that for the next go round. Would that?
You tie that to your outcomes group too. I mean,
Yeah.
Because that should be the same. So be careful before work. I'm going to help you, Bob, because I mean I agree. But there's also.
She's going to help you.
I'm going to help you. So let's go through the care coordination.
Well, I hope it all makes sense.
No, it makes
what I
sense.
said.
Yeah, I'm trying to translate it a little bit. But it does make sense. We'll go from there on the care coordination and look at the quality measures. And Cindy even said this, you know, do you look at evidence-based practice within a certain service? Not under the current service definitions of the current rate. Absolutely not. You know, it's just not supported that way. So I think it's important to have this quick conversation before we go into the rate setting conversation. But you could look at the service definition aspect of it too. And that's some of the concerns that have come up in some of the other groups that we've been in. If we look at a blended service, like what Cardinal has done and what we're moving to with integrated supports, we appreciate the flexibility. But here's what's happened with the Cardinal is just now they've changed the rates. 2 distinct services, the higher level, skill building has gone down, personal care has gone up. It's a move, but nothing has changed within the service definition. The expectation is the same.
Right.
So there is some concern out there about, well, if we're moving that way towards integrated supports, how are we really going to do those kind of intensive services within that definition? Can you do that within that definition? Are we going to tier that definition in some way? Are we going to look at enhanced? You see what I mean?
I do.
Because that's lost somewhere. Do we need to do another service definition, or are we somehow going to be able to do it within that? When you think about, and I hear from parents a lot, who would rather have 5 hours a week of intense, I want some training, some skills training, and then a lot of support, you know, to help cover the child care thing. Are we going to have the ability to do that within the current constraint?
Yes, it does. It does. Ms. Short?
All I wanted to say was, as far as the habilitative services and the, if we're going to this whole person care with Medicaid reform and all of that, and it's what the doctor ordered, and the idea that habilitative care is not rehabilitative, and these LMEMCOs are trying to reduce habilitative services based on a rehabilitative definition. And unless parents are informed about what the difference between habilitation and rehabilitation is, they get screwed out of services. And care coordinators are under whatever pressure they're under. And as far as that blended rate, I looked at if Katie was in PBH. I mean, every time somebody tries to change this goofy waiver, Katie's services end up costing more money. Because the way Katie's services are right now today, her 8 and 4 split, it's $24 more a day if she were in PBH than if we keep the existing rates at Smoky Mountain. So, whatever. Somebody apparently isn't paying attention. But again, if it's a medical doctor who's prescribing, then utilization review, utilization management, for whatever reason, just seems to blow off the fact it was an actual medical doctor. I mean, whatever it is they're looking at isn't giving any weight to a medical doctor. So that's what I wanted to say.
If I could add, I think that there's a education difference here between rehabilitative versus habilitative, but parents and providers need to know that there's a difference between habilitative and custodial care. And back when I was a reviewer at one point in my life, it was just the saddest thing to me to see this individual who was living in the community, sitting in a room, fairly isolated, and was not engaged. Mm-hmm. And people must be engaged, no matter what model or service definitions, they must be engaged. There must be adequate services and funding for those services to support that engagement in the community. And if we miss that, and somebody's sitting in a room and their engagement is they're sitting in front of a TV, we have done a great disservice to people.
Well, we're doing it currently to a certain degree. I mean, I think all of us that have seen plan reviews have seen some of the stuff that comes through. I mean, it's occurring today, so don't disagree with you. Some of the stuff I've seen has really just disturbed me.
Can I just say something? I think the other thing to say is, from our perspective at the MCO, it happens regardless of what the rate is, regardless of what the service is. And I don't mean to generalize across providers, because I know it's not across providers. But frequently, no matter what you call the service, no matter what you put in that plan, when we monitor, it looks like personal care.
Uh-huh.
So, it's not as easy as a rate. It's not as, it's a complicated situation.
But Rose, you would say, I guess in response to that, if you were going to fund a service at a personal care level, you should expect the functions that are performed to be.
Well, we will be talking about rate setting very shortly.
Right. But I know what you're saying, Rose. I think I know what you're saying, and agree with you somewhat that certainly occurs. Either one of those that Rose is talking about are not minimally adequate.
Yeah.
But, what has happened in CBH, as a provider, what has happened, I do know that in the beginning when we did assessments and what is the progress and how, as much as people complained, because probably the rates didn't really support, moving in that direction, but that's if we're going to talk about really doing some intense training, I will say that on the autism, intense training specific to something, you want to see some outcomes, you want to see progress, you want to see that, and you do a little bit of a higher rate, but you measure it around that. And
right.
That's common there. Right.
Ellen?
I had an incident that happened to me about 2 weeks ago. My boyfriend and I were both sick at the same time. That never happens. But I needed some meds, cough meds. And didn't feel like going to go get them. So I called everybody. I called everybody to go get me some cough meds. There was nobody to go get them. There was nobody. So what am I supposed to do? How am I supposed to get my cough meds? Well, I ended up going to get them next day because I had to go to the doctor anyway. But it was just ridiculous. So there should be something in the plan or something in some way or another, so that when people are sick, that we can go get so when people are sick, we need some meds. We know what we need. We tell the staff what we need, but they didn't pick it up right. So, what am I supposed to do?
So like some kind of an emergency.
Yeah, it was an emergency, and I didn't want any staff over there.
Okay.
For 2 weeks. I didn't have staff over there for 2 weeks because I was sick. And what am I supposed to do? I didn't want staff to go get it. I didn't want the staff to get sick. And my staff was sick.
Kenneth wrote it red, so
Yeah,
that
I wrote it
really
red.
finish that back.
Thank you.
Yeah, I think that's really a point just to sort of emphasize that. I don't know on a really detailed level about mental health services, but I do get the impression that because mental health is more of a crisis-based system, at least as far as, the delivery of service, and a lot of people with mental health issues are their needs are relatively simple until they go into crisis, at which point it's like, all right, let's engage, crisis mode. And I feel like that's something that maybe we could learn a little bit more from on the DD side and borrow a little bit more from it, because while DD is not crisis-based and it is long-term supports and services, crises do happen. And I feel like right now it's not really firmly entrenched anywhere in any kind of service definition, other than saying, if crisis happens, then you can modify the plan or whatever for the time of the
Well,
crisis.
one thought, and we definitely have not gone down this road, but one thought that HSRI had thrown out there at one point would be like a $5,000 lifetime emergency fund. And that's not really what we're talking about today, but I'm just kind of, we had back and forth about how that would be structured in a lot of different ways, and that was one of the things they suggested.
Yeah, but not even just speaking monetarily, even in terms of like execution, as far as how making sure that both providers and clients know here's what's going to happen in the event of a crisis, rather than saying, well, if there's a crisis, we'll make sure to address it. You know what I mean? Like,
Yeah, I think you guys kind of brought that up during one of the other presentations.
Proactive versus reactive.
So,
right. Yeah, but I definitely just want to emphasize that, because it's definitely...
Ellen?
We also need to know what is a crisis and the difference between a crisis and all these other things. Because people may think a crisis, oh, well, I'm having a crisis now because I can't get here. But I could get here if I had called TTA.
Okay.
But I did, or something like that. Now, crisis is to me, or when my wheelchair goes down and I can't get around, or something like that. Or,
So we'll have to define some parameters.
yeah,
Right, what is the price, but-
yeah, please.
So you would say that 5,000 are a good idea.
And-
We talked about unmanaged.
Yeah.
$7,000 or $10,000.
Mhm.
Make it $10,000. Kathy?
I don't know if they'll be $10,000, Ellen, I mean, we'll
Well,
have to.
it's gonna cost a whole lot more to get an electric wheelchair than it does to,
Well, now, see, that wouldn't necessarily come under the crisis, though. That would be probably your goods and services
But-
under,
but see, I only get $2,000 and I only get $2,000 for business services. So that little pot of money, that you're talking about putting aside for a person,
yes, we would absolutely have to put some kind of guidelines on it, yeah.
Yeah.
It's not fleshed out as an idea at all, I'm just kind of throwing it out there as something that had been suggested for things like a one-time crisis emergency type situation.
well, this happens once, this happens once to me. I only get sick once in a while. Now, my boyfriend only
You
gets.
better knock on wood, Ellen.
Yeah, well, I better get up there and knock on wood then. You all better invite me up table then, so I can knock on wood.
But anyway.
But I'm just telling you what happened.
Right,
No.
thank you, yeah.
Yeah, I think that's good, and I think it's something we're gonna have to think about.
And it wasn't a real crisis, but it was, it was.
Emergency.
Mhm.
When you say
By the time of the individual, yeah.
Of the individual?
Yeah, or the waiver, I guess.
The waiver.
Very
I don't remember.
Usually it's the waiver.
That's
I don't even
Well,
know.
after the
pretty important
It's a
distinction.
year ago now that we had this conversation, I don't remember
Because
what,
I think the lifetime of the waiver is like 3 years,
3 to 5 years.
what was the waiver, I don't remember.
whereas lifetime of the individual is
Probably,
hopefully going to be longer than that.
yeah. And so I guess actually this might be a good moment to just bring up another piece of future planning information, and that is that HSRI is now in possession of all of our current spending data and all of the SIS assessments that they needed, and we're planning to bring them back here mid to late January. They'll be talking to we'll hopefully set something up with the CEOs and CFOs and the MCOs first, and to present data to them, and then in that same week, have them come here and kind of present what they found, and we should have enough of a data set at that point in time to be able to delve a little further into the weeds, to start looking exactly at what these bands are going to kind of look like, and start talking about some of these decisions that are going to have to be made from an overall policy level, I guess, if you will. Because up till now, what we've been doing, and this is also important, we've been talking about bits and pieces of different sections, but there's going to be some big policy decisions that also need to be made, like where the bands are going to be. Are you going to have that $5,000, like for the waiver, I guess, fund? But, some of those kinds of decisions are coming too. So I think that's about the time frame that we're kind of looking at for them to come back with a complete data set to be able to talk intelligently about what our specific state looks like. Yes, Ellen?
Can you make that so that DWAC can see it here too?
We can maybe
Can we
see-
combine DWAC and this board together?
I can talk to the DWAC folks, can't promise you that. I can say we can always have the presentation at DWAC and maybe somebody from the state gives it.
Well, the DWAC would be interested.
Okay. You're
Makes
DWAC,
sense
right,
for
Renee?
them to come.
I'm at the DWAC.
Well, Renee, I think that you're planning person for the state
Yeah.
though, so she'll take that back.
Okay, thank you, Renee.
Would make more sense to have them come here.
It was a while back,
We got a little bit of time. Any other thoughts about Canvas utilization management or any other overall discussion points or thoughts, questions? No?
I'll just reflect on that for a second and let you all are break.
Well, you're gonna have, we got half an hour unless Roger comes early, basically. And Roger's never early.
Well, then I have plenty of time. So just, I think it's just important to really hone in, and I'll start to sound like a broken record, I'm sure, but health and safety is an important outcome. And we know the waiver must contain a heavy component on that, but we now know from our conference recently in Pinehurst and the outcomes data that we've got access to now over 20 years, that it's not necessarily predictive of other positive outcomes for people. So we don't want to undermine the importance of health and safety, but we have to consider how to put its weight where it should be.
And I didn't mean to phrase it that way. Let me be specific about why I don't like those measures. It's things like whether or not a box is checked on a plan.
Right. Right. And that's a process that may or may not have anything to do with someone achieving something.
That's really what my issue is with those measures.
I hear you.
So let me just clarify that.
That's important. The other is we know health and safety shouldn't go away. But as we think about the measures, let's pay attention to those that we know have the potential for a ripple effect to other outcomes in the lives of people. So not just going into community, but being a part of the community in some way. There's a difference between the two. Doing something meaningful with your time, which I think was already discussed at length, not just sort of waiting around or something. And I think we know that. But
right, but we're going to have to really think about how you define that. How do you measure that? What does that mean?
And I think there are some of those measures out there that we need to look at. And we can pick and choose out of that, but I think we ought to use, we do have some data coming in, and we have enough with the core indicator data. CQL's personal outcome measures are two strong pieces. And I think we can take what we're learning from those things and figure out a few that we know we want to consistently look at. I would really encourage that.
Yeah, I mean, we're going to be stuck with the check boxes on the form. We'll still have to send that back to CMS. We'll still have to sit there and count them regardless of whether there's any real meaning to it.
And
until they change their requirements, we're going to be stuck with that. But again, you can add anything else you want to that. It's a base, not a ceiling.
But if you set those check boxes up to measure, not just, well, for instance, if the check box is about a process, did you do this? Yes, we did. It's done. But we have no idea what the outcomes are.
Right.
If, on the other hand, the check box is against, an outcome that's predefined, then I'm checking off and we know that this thing actually occurred. We don't care how it happened. We can look at that in a different way. But the big concern that we have is,
I mean, yes.
what is the outcomes? That's why I get concerned anytime we start talking the differences between processes and outcomes.
Yeah.
Process locks us into doing it this way and this way every time, regardless of what the benefit is or isn't. If we're looking at specific results that are defined by personal benefit, those outcome measures that may not necessarily be high on the radar, but really when you, and I remember that the one conversation we had at Pinehurst, that when these things are in place, all these other things are happening. These are critical factors, these are causal factors, non-symptomatic factors. Looking at those kinds of outcomes as results, then a checkbox works just fine, because you put the process of checking it to work, making sure that the outcomes are there, and not just did you do the task.
Chris, I think you'll find when you look at this list of measures that you'll find some of them are just not robust at all. Or you probably have seen them and know what I'm talking about. Therefore, agree with me. Yes, you should. No, but I don't think that they're getting at what I think we want to see as a system.
I mean, again, or to CQL specifically, the HCBS crosswalk really comes from that. So, because we're going to have to pull all that together.
Now, is a timeline for that, if that's what you're asking for. There is and I wish Deb hadn't left, she's the only person, yep. Oh, there she is. Do you want to give an update, Janet, or do you, I mean, I know where they're at right now is there's been a draft of a bunch of things, or a draft, that will hopefully go out to the stakeholder community in late January, February, with the goal of being, there's March 17th deadline. And that will have to come to this committee at some point, because it will definitely be part of this waiver work. What do you want to add? Does everybody know Janet?
Hey, Janet.
Janet.
Tell us who you are, Janet. No pressure.
No pressure. Thank you. It was a bystander here today, and I'm Janet Green, I joined the division about 6 weeks ago, and moving
She's
every.
got it, hit the ground running.
Pretty much, I can echo what Kathy said. Our target is 1-2 per rollout on a draft plan internally that has come from a lot of information, but everything is pushed out. There is a timeline. We're rolling it out to our provider boards, not on a plan, self-assessment before we have. So it's fairly comprehensive, but the date is March 17th, and we have to meet it. So, but there is.
You do like 6 listening sessions, I think.
6 listening sessions.
They're gonna reconvene a stakeholder.
Hopefully that will be firm today as soon as they can nail schedules down for the attendees and the venue. We tried to make it a 2-hour driving distance, given consideration. I mean, look, Monica up there, because we're looking at all 3, DA, C, and innovation, of course. So it's going to be an extremely busy time from January 1 to March 17th.
And then, so Renee, at some point, when we get a draft plan, we'll send it out to y'all, and we'll do this group also with it. So you'll be sick of looking at it, Carrie, probably. but so that'll be incorporated too. Was that your question / point?
Well, just that it incorporates the outcome. It would be nice if it all flowed together.
That's
What
the
did you
goal,
say,
yeah.
Carrie?
Just that it would be nice that it flows together, along with Chris's point. I'm sticking up for Chris, sticking up for all the work that you're doing, making sure all, giving some sort of point in that.
Yeah, we'll have to incorporate those into this waiver. And I guess to the point of a new waiver, I don't know if I'm looking at exactly, but for, I guess to all of my staff, if we do the supports waiver, there's not going to be a gear-up time. It'll have to be for these new requirements. So, but anyway. Ellen, you had your hand up?
Well, I was gonna ask, okay, what did, Chris, what were you saying about check boxes? I mean, were you saying about, I mean, I don't understand. I wasn't at the Pinehurst.
I'm calling John out. He was
John's
the one
the one
Okay,
that
okay, whoever said check boxes, I don't,
deflect that.
I didn't understand.
Yes.
John, what is it?
With the checkbox?
Yeah.
And it goes back to original question.
Nope, all yours.
Well, anytime you have a process that we're reviewing, it is much easier. It's kind of like going through school when you have the true, false, and multiple choice tests. It's a very subjective criteria. It's just down the line, you check the boxes, boom, 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 and there's no thought that goes into it.
You're using two big words for me, subjective.
If we are measuring a process, did they visit this person 3 times? Yes, they did. We can check the box and done and walk away feeling pretty good that we did exactly what we said we were going to do. But it says nothing about how that person, what happened in that interview. Did they actually meet the needs? Was the life of the person enhanced because of those visits? We have no information other than they did exactly what they said they were supposed to do, and we checked the box. If those check boxes are based on outcomes, was their life improved by, and defining that in some fashion, then the checkbox actually works for us, because we can go by and say, yeah, that actually did occur, and your life was improved.
Like the, personal, what was the one that you did over DTTI?
When I used to train that,
Yeah.
those are personal outcome measures.
Okay.
Yeah.
Well, the personal outcome measures
Yes.
are
Which-
stupid.
That's on you, Chris.
Because, I mean, they are stupid.
We may have to have a little offline conversation.
I didn't do that.
We're having online conversation now. Because some people can't answer those. Some people, like me, can't answer them. But like a person with autism can't answer it.
But I'm not sure I quite understand all of that. But what I was, we should talk a little more, but when we think about a person's life and we think about the idea of an outcome, then it is about their life. There isn't one specific way that ought to happen. But it's looking at things like getting my cough medicine when I need it.
Okay.
That's an outcome.
Yeah.
Or learning about other options of things that I might find interesting to do with my time. That connects to an outcome.
Okay.
So how you define that is going to be different than how Katie defines
Yeah.
that, different how than I define that. So what it provides, though, is these are things that we know people have said are important for us to pay attention to because it's about quality of life, not about a checkbox.
Okay.
That's the difference.
Okay. Thank you.
So,
We are done
but we can
without
talk
those.
some more, too.
Yeah.
Can I ask?
More specific.
Okay, maybe 10 minutes to break.
Yeah,
It's
we
really
got
hard
another
to
10 minutes
hear.
for like
Speak a
miscellaneous.
little
Very good.
louder.
The only other thing is, I don't know if there's any other comment about the SIS stuff that we passed out, that you got previously either. I think it was a follow-up from the last meeting, but it's also an opportunity if you have any comments on that. But yes, ma'am.
I was just curious if there had been any discussion of the service definitions about any new service definitions, or where are we?
We are still working on integrated support.
Outside of ABA, is this an ABA conversation?
No,
or-
Karen Lucan, what is this?
I was not at any of the previous meetings, but my understanding is there was a discussion about healthcare coordination. In our project, we've heard from people that need to have navigation services, so I had sent to Deb some compilation of information, and then I've been in contact with some other states to also find out how they're approaching healthcare coordination and navigation between systems of care. So I think that's what Carrie's referring to.
I don't know, so I'm gonna take that away from you unless, take that away from you unless you're gonna jump in there. And I will just say that actually is a bigger conversation about, I would say, system reform in general, as we're looking towards what we're gonna do with ACU. I mean, and we're having these conversations right now. I mean, obviously a lot of it depends on what the General Assembly does. But because it's gonna be a navigator beyond just this
Beyond just the waiver.
yeah, if we're gonna go that direction. So, yes, we are having that conversation in a much larger system discussion.
And I think from individuals we've spoken with, because we're in this system, and this is the system they're living in, what are the opportunities now that present to address these issues while looking towards the future for the bigger system?
And
which I
you're
understand.
referring to what you're doing out in Smoky and out east, is that right?
Well, the medical health home
Pilot
project.
project for
Right.
navigation
But
navigator.
hearing from people that the issue of care navigation, how it's different from care coordination, the loss of case management.
Yeah.
So understanding the system, the big system is changing, but people still have to live in the current system for the innovations waiver in 2015 and 16, and just how to look at some of those concerns.
To be a navigator, I don't know if we'll be able to fund a service in that sense of what you're asking for. It may be a question of trying to take a look at the elements from that and what we can maybe feed into the care coordination expectations or the community guide expectations, if there are any. I mean, but I think that's maybe it's a conversation we need to come back and have because I think you're doing great stuff in these pilot projects that you're doing. I don't know, I mean, it might be something that we could do further iteration of this waiver, but for this time around, I think it's going to be hard to break set for a new service.
And that's what, this was in the service definition presentation that Jesse and Jamie gave. That was also Cindy, so we also indicated that was the one that was missing.
Navigation.
Navigation. Right, because recognizing that system reform will take at least 2017.
No. It's being probably,
Right.
probably.
Yes, probably.
So, we can take that back and we can take a look at it, but I will just caution that, and that's what I will say is, as we talk about Warren Rogers shows up, I mean, I think it's just gonna be hard to, especially with all of the other shifts that are gonna happen as we try to do this, to try to like figure out the cost of a new service into that. I think it's gonna be a little complicated, honestly.
So then, but to integrate sports, is there a conversation about banding or enhanced level, or do we need a separate inclusive service definition?
We haven't talked about that yet.
I don't think we'll see what we do. I don't think that it'll wind up being a waiver service. I think it's gonna wind up being a state plan service. And I don't know why I'm doing it like that, but I think it's gonna, I think that's what it's gonna wind up looking like though. And again, we're in the very preliminary stages of that one too, but in the sense that right now what we're doing is we're trying to look at some of the definitions that have passed, some of the spas that have passed, and how they've kind of structured their staffing around those kinds of things. And so once we kind of get our arms around that, we'll start, I'm looking at probably in January to get some stakeholder stuff together about that as well. Yeah, I mean, the goal is March. So, yes ma'am, if you're...
Sort of back to that navigator idea, do any of these groups that are meeting, is there DSS guardians participating?
You mean for the navigator conversation?
Well, just the idea that as this whole system and how this waiver is tying in with Medicaid reform or DHHS reform, are actual DSS guardians participating?
In some, I mean, it's hard to answer. In some things, not in everything, but in some things, I don't know how to answer you better than that.
There was a guardianship subcommittee of the General Assembly early last year, and I remember part of those committee meetings, there being some discussion about how DSS guardians can't figure out how to navigate the LME MCOs. So are they a part of all, because that's who Katie's going to have. So this reliance on families, is a theory to me. I mean, these DSS guardians are, so, and especially with the idea that Smokey is going to, well, if we regionalize Medicaid, then Katie loses her primary care physician and her neurologist, because they're not in Smokey's region. So I guess Katie moves to their region in order to keep her doctors. I mean, and as a DSS guardian, I just really wonder how an actual live DSS guardian from each LME MCO, are they participating in all of this? Just saying, we can move on.
Okay. I wrote it down. I mean,
Thanks.
they probably are missing probably from some discussions as I'm sitting here thinking about it. I mean, DSS and those issues are, I mean, they're part of several conversations.
Yeah, it's all
I hear you.
swirling.
Even Chris wrote it down.
Yeah.
Incorporate that into the conversation, yeah.
Kathy, the only thing I would add is I think most MCOs try to have regular ongoing meetings with their other partner agencies like DSS to sort of keep people apprised of what's going on. It's not a perfect system by any stretch, but I think those efforts are out there.
Yeah, no, I think you're right, all the MCOs do try to meet with DSS. How that communication flow happens from there is sometimes.
But that isn't what that guardianship committee found. Though the DSS representative at that guardianship subcommittee, they were very clear about not understanding how to get their mental health clients.
Right, but probably Rose or somebody, let's just say Rose talks to, I don't know, Jeff, who's like the charge of DSS, but Jeff doesn't get around to talking to like Mary, who is the actual, guardian, and it's just communication flow sometimes, I think. Yeah. Yes, ma'am.
Maybe you can go to the guardianship conference next year and explain to the guardians.
That would be
who,
one place for
how it works.
Yeah,
And if they have any questions, then they can ask you all. They probably do.
But that would be one avenue, sure.
That would be one avenue. Yes.
So we can have a minute or two, or we can take a break until Roger shows up, my money guy friend. Any other thoughts or comments?
Okay, say deal and I'll cut off.
Not really.
Just follow the timeline.
Okay, so he should be here by 3 because we gave him 3 to 4 on the agenda, so a 15-minute break.